Welcome to Cardiopulmonary Rehabilitation. This is from Chapter 55 in Egans. Learning objectives for this video. Learning objectives include being able to state the definition and general goals of a pulmonary rehabilitation program, being able to explain the rationale for exercise conditioning and psychosocial support of patients with chronic pulmonary disease, describing how to evaluate and select patients for pulmonary rehab. Describing pulmonary rehabilitation program design, including its format and content. Listing the educational content to be addressed in a pulmonary rehab program. Describe the implementation of a pulmonary rehab program, including staffing, facilities, scheduling, class size, equipment, cost, and reimbursement. You should also be able to discuss the outcome measures that can be used to evaluate a pulmonary rehab program. Identify potential hazards associated with pulmonary rehab, and compare the focus of pulmonary rehabilitation to that of cardiac rehabilitation. Let's start with some definition of and goals for pulmonary rehab. Pulmonary rehab can be defined as the restoration of the individual to the fullest medical, mental, emotional, social, and vocational potential. Pulmonary rehabilitation is the art of medical practice with an individually tailored, multidisciplinary program that is constructed through accurate diagnosis, therapy, emotional support, and education that stabilizes or reverses both the physio and psychopathology of pulmonary diseases and attempts to return the patient to the highest possible functional capacity allowed by his or her pulmonary disease and overall life situation. The overall goal of pulmonary rehab is to maximize functional ability for the patient and to minimize their disability. Other goals include control of symptoms and to improve overall quality of life. Pulmonary rehabilitation isn't meant to reverse or stop the progression of disease, but it can help improve a patient's overall quality of their life. Pulmonary rehab has been around for a while. It isn't a new concept. In 1952, Alvin Barak recommended reconditioning programs for chronic lung disease patients to help improve their ability to walk without shortness of breath. However, decades had to pass before clinicians actually paid any attention to this concept. Instead of having their patients participate in reconditioning programs, most doctors simply prescribed oxygen therapy and bed rest. The result was a vicious cycle of skeletal muscle deterioration, progressive weakness, fatigue, and increased levels of shortness of breath, even at rest. Patients became homebound, and then room-bound, and then eventually bed-bound. Finally, in 1962, Pierce and Associates published data that confirmed the value of reconditioning. They observed that patients with COPD who participated in physical activity exhibited lower pulse rates, lower respiratory rates, better minute volumes, and lower carbon dioxide levels during exercise. However, they also found that these benefits occurred without significant changes in pulmonary function. Their PFT values didn't change much. Soon after, Paez and Associates showed that reconditioning could improve both the efficiency of motion and oxygen consumptions in patients with COPD. After that, Christie showed that the benefits of reconditioning could be achieved on an outpatient basis. That was in about 1968. Since Dr. Christie's work in 1968, many other investigators have continued to research the benefits of pulmonary rehab. Gradually, the medical community has come to value and appreciate pulmonary rehab for patients with COPD and other pulmonary disorders. When pulmonary rehab is combined with smoking cessation, optimization of blood gas results, and proper medication use, it often offers the best treatment options for patients with symptomatic pulmonary disease. Programs for pulmonary rehabilitation are founded on the sound application of current knowledge in clinical and social sciences. In 2006, the American College of Chest Physicians and the American Association of Cardiovascular and Pulmonary Rehab, the AACVPR, released their evidence-based guidelines relating to pulmonary rehab, aimed at improving the way pulmonary rehab programs are designed, implemented, and evaluated through patient outcomes, based on hard science. Let's talk about physical reconditioning. At rest, an individual maintains homeostasis by balancing external, internal, and cellular respiration. Physical activity, such as aerobic exercises, increases energy demands. To maintain homeostasis during exercise, the cardiorespiratory system must keep pace. Ventilation and circulation increase to supply tissues and cells with additional oxygen and to eliminate the higher levels of carbon dioxide produced by the metabolism. Oxygen consumption and carbon dioxide production also increase in a linear fashion as exercise intensity increases. If the body can't deliver sufficient oxygen to meet the demands of energy metabolism, blood lactate levels will increase above normal. Patients with COPD who lack adequate pulmonary function have severe limitations for their exercise capabilities. Their high rate of CO2 production during exercise results in respiratory acidosis and shortness of breath out of proportion to the level of activity. In addition, as ventilation increases, the rate of oxygen consumption in a patient with COPD increases significantly. Together, these factors limit patient tolerance for any significant increase in physical activity. Pulmonary rehab includes efforts to recondition patients physically and increase their exercise tolerance. Reconditioning involves strengthening essential muscle groups and improving overall oxygen utilization and enhancing the body's cardiovascular response to physical activity. The image shows how the body responds to exercise. Ventilation and circulation increase to supply the tissues and cells with additional oxygen and to eliminate the higher levels of carbon dioxide produced by the metabolism. Oxygen consumption and carbon dioxide production also increase in a linear fashion as exercise intensity increases. If the body can't deliver sufficient oxygen to meet the demands of energy metabolism, blood lactate levels will increase above the norm. Shown here are changes in oxygen consumption with increasing ventilation in a normal subject and in a patient with emphysema. You can see body temperature, body pressure saturated, volume of dry gas at 0 degrees centigrade and at 760 millimeters atmospheric pressure. Let's talk about psychosocial support. If the overall goal of pulmonary rehab is to improve the quality of a patient's life, physical reconditioning alone isn't enough. Patients with chronic pulmonary disease need psychosocial support. COPD can negatively affect a patient's overall outlook and reduce their motivation to complete a pulmonary rehab program. There is a well-established relationship between physical, mental, and social well-being in people. The progressive nature of chronic obstructive pulmonary disease negatively affects his or her outlook on their disease and can reduce the motivation to adapt to the disease. Patients with COPD often have a tendency to develop severe anxiety, hostility, and stress as a direct result of their disease. This is because patients are fearful of economic loss and death. Psychosocial support in combination with physical reconditioning is needed to create the best possible outcome. Goals of a pulmonary rehab program. Pulmonary rehabilitation programs vary in their design and implementation, but generally they share some common goals. Some of these goals are control of respiratory infections, basic airway management, improvement in ventilation and cardiac status, improvement in ambulation and other types of physical activity, reduction in overall medical cost, reduction in hospitalization, psychosocial support, occupational retraining and placement when and where possible, family education, counseling and support, patient education, counseling and support, and control of respiratory infections. The education component of the program is vitally important. You can see a respiratory therapist pictured here teaching a class to her patients. Objectives of a pulmonary rehab program. Pulmonary program objectives are specifically defined and structured in a measurable way, with strategies that can be tailored to ensure the maximum results and benefits for the patients. Demonstration of program effectiveness also becomes easier and more acceptable by the medical community when these objectives can be measured and met. However, benefits realized by participating patients are not always easy to identify and may be controversial. Some of the objectives that you may see are development of diaphragmatic breathing skills, development of stress management and relaxation techniques, involvement in daily physical exercise regime to condition both skeletal and respiratory muscles, adherence to proper hygiene, diet and nutrition, and smoking cessation, if applicable. Proper use of medications, oxygen and breathing equipment, application of airway clearance techniques when indicated, focus on group support, and provisions for individual and family counseling. Patient evaluation is vital. Before beginning a pulmonary rehabilitation programs, clinicians need to define and establish criteria for entry or selection into the program. They need to be aware of any comorbidity a patient may have, along with the effects exercise may have on blood chemistry and a patient's overall physical status. Patient selection requires comprehensive evaluation and testing. Evaluation may include a complete patient history, a complete physical exam, chest x-ray, CBC, EKG, pulmonary function testing, and exercise evaluation like a 6-minute walk test or shuttle test. Relative contraindications to exercise testing include some of the following: inability or unwillingness of a patient to perform an exercise test, severe pulmonary hypertension or cor pulmonale, known electrolyte disturbances such as hypokalemia or hypomagnesia, resting diastolic blood pressure greater than 110 millimeters of mercury, or a resting systolic blood pressure greater than 200 millimeters of mercury. Neuromuscular, musculoskeletal, or rheumatoid disorders that are exacerbated by exercise. Uncontrolled diabetes. A saturation or SpO2 less than 85% with the subject breathing room air, untreated or unstable asthma, untreated or unstable angina or angina with exercise. An exercise evaluation can help differentiate among patients with primary respiratory or cardiac limitations due to work capacity. Besides helping to differentiate between the underlying cause of exercise intolerance, test results can assist in placing patients in the appropriate type of rehabilitation program, either cardiac or pulmonary. To minimize patient risk during exercise evaluation, certain safety measures need to be implemented. First, the patient should undergo a physical exam prior to the test, including a resting ECG. Second, a qualified physician should be present throughout the entire test. Third, emergency resuscitation equipment, a cardiac crash cart, monitor, defibrillator, cardiac drugs, and suction equipment and airway equipment must be readily available. Also, staff conducting and assisting with the procedure should be certified in both basic and advanced life support techniques. Also, the test should be terminated promptly if indicated. For test preparations, patients should fast 8 hours prior to the procedure. If the purpose of the test is to formulate an exercise prescription, the patient can take his or her regular medications. The patient should wear comfortable loose clothing and footwear with adequate traction for treadmill or ergometer activity. The mouthpiece or face mask used during the test should be sized to fit properly and comfortably with no leaks. Test conditions should be standardized as possible to allow for comparison of results before and after rehabilitation and periodically from year to year as the treatment patient is followed. Program design. A good design helps to achieve specific program objectives. With the selected group of participating patients, key design considerations involve both format and content with emphasis on patient reconditioning and education. Programs can use either an open-ended or closed design with or without planned follow-up sessions. With an open-ended format, patients enter the program and progress through it until they achieve certain predetermined objectives. There is no set time frame. Depending on his or her condition, needs, motivation, and performance, the individual patient can complete an open-ended program over weeks or months. This format is good for self-directed patients or patients with scheduling difficulties. It also may be the best format for patients requiring individual attention. The major drawback of the open-ended format is a lack of group support and involvement. In addition, insurance reimbursement may be a factor when the program is open-ended. The more traditional or closed design uses a set time period to cover program content. These programs are usually run anywhere from 6 to 16 weeks, with classes meeting 1 to 3 times a week. However, insurance coverage may dictate how many sessions make up the program. Medicare covers 36 initial sessions with possible coverage for another 36 sessions if the patient qualifies and would benefit from the additional rehabilitation sessions. Class sessions usually last up to 2 hours. Presentations are more formal and group support is involved and encouraged. A major drawback to this format is that the schedule determines program completion rather than the objectives. However, Most programs allow patients to re-enroll if the anticipated improvement is not achieved. Regardless of the format used, long-term improvements cannot be expected without planned follow-up. Regardless of the format used, long-term improvements cannot be expected without planned follow-up. Follow-up must be ongoing and available to all patients who complete the program. Frequently, this is an essential element of the process. It's difficult, especially when it's not covered by most insurance plans, but program coordinators and directors must ensure that it's routinely scheduled. Follow-up or reinforcement can be open-ended, available during regular rehabilitation sessions and offering open attendance, or it can be scheduled weekly, monthly, bi-monthly, quarterly. The important thing is to have some type of follow-up available. Content. The content of a rehabilitation program usually combines physical rehabilitation with educational activities. Let's talk about physical reconditioning first. The physical reconditioning components of a pulmonary rehabilitation consist primarily of an exercise prescription with a target heart rate based on the results of the patient's initial exercise evaluation. For most patients, an initial target heart rate is used setting the Carvonen's formula, or estimated at 20 beats above their resting heart rate. The Carvonen's formula is maximum heart rate minus resting heart rate times 50 to 70% plus the resting heart rate, where maximum heart rate is the maximum heart rate at the limit of exercise tolerance and resting heart rate is just that, the heart rate at rest. A good target exercise heart rate for a patient with COPD with a maximum heart rate of 150 beats per minute and a resting heart rate of 90 beats per minute would be 150 minus 90 times 0.6 plus 90, which would equal 126 beats per minute. Because of the severity of ventilatory impairment, some patients begin exercise reconditioning without a prescribed target heart rate. Exercise prescription typically includes the four related components: lower extremity aerobic exercises, timed walking, a 6 or 12-minute walk, upper extremity aerobic exercises, and ventilatory muscle training using progressive resistance. To ensure success with physical reconditioning, patients must actively participate both at the rehabilitation facility and at home. While exercising at the facility, patients should be monitored by pulse oximetry. You should also ask them their Borg scale. The Borg scale is a patient-perceived shortness of breath, 0 being no shortness of breath, and 10 being the most shortness of breath they've ever had. Blood pressure measurements may also be made, but these are usually done at the start and at the end of the session unless a patient's condition dictates otherwise. In addition, exercise sessions should be upbeat and lively. Music helps, as well as a positive atmosphere. Clinicians must remember that these patients are ill and require a nurturing attitude from all team members, family, and the group. To ensure compliance with the program, a daily log, diary, or sheet is completed. Let's talk about the educational components for a minute. The educational portion of the program covers topics that are both useful and necessary to the patient. Some topics covered during a 12-week pulmonary rehab are the introduction and welcome, respiratory structure, function, and pathology, breathing control methods, relaxation and stress management, proper exercise techniques and personal routines, secretion clearance techniques, home oxygen therapy, medications and their use, medications, MDIs and spacers, nutrition, recreation and vocational counseling, activities of daily living, and follow-up planning and graduation. During some of these educational components, you may have outside help. For example, for dietary guidelines, you may ask a nutritionist to come in and give that particular talk. An occupational therapist may do recreational and vocational counseling. Psychosocial and behavioral component. Psychological and emotional stress is a common problem for patients with moderate to severe chronic respiratory disease. Pulmonary rehab programs can bring in experts, such as counselors or psychiatrists, or psychiatric residents, to implement psychosocial and behavioral therapies that provide patients with the opportunity to learn coping strategies like visualization techniques and breathing techniques. This component is useful for patients with anxiety, depression, or both. The multidisciplinary team is the heart of the pulmonary rehab program. Staffing should include nutritionists, occupational therapists, a medical director, nurse practitioners, transplant nurse practitioners, respiratory therapists, social workers, exercise physiologists, clinical psychiatrists or psychologists, nutritionists. All staff conducting the program in the gym should be certified in both basic and basic life support and advanced life support. In other words, BLS and ACLS. Some of you may even have PALS and NRP as well. Here's a visual of the team. This is a typical pulmonary rehab gym. Facilities have to be easy to reach, accessible by public transportation, have available parking. Rooms should be spacious, comfortable, and well lit, along with well ventilated. There should be extra rooms for education and counseling. Scheduling. Class times need to be scheduled at a time that's convenient for patients, not too early in the morning, but not too late at night. Several class times should be available. A morning and an afternoon class are best. Traffic patterns, bus schedules, and availability of rides are important things to consider. Let's talk a little bit about class size. An ideal class size is 3 to 15 patients. This will depend on your staffing. How many RTs do you have? If you only have one RT, you may only have 3 patients at a time. If you have 5 RTs, you may be able to have 15 patients. Equipment. Classroom equipment to facilitate teaching is needed. You'll need a blackboard or a flip chart, a projector or PowerPoint projector, and formal learning packages. These can be purchased or made. Also, you'll need gym equipment. Physical reconditioning equipment like stationary bicycles, new steps, treadmills, rowing machines, arm ergometers, pulse oximeters, inspiratory resistance devices, emergency oxygen, and a crash cart should all be in the room. Factors that affect pulmonary rehabilitation program costs. How much does it cost to market your program and promote it? How many personnel do you have that are involved in your program facility and your administration? Is there a manager? Does your manager double as the RT? What space do you have? What space and utility expenses do you have? Do you have audio-visual exercise and monitoring equipment? You've got to purchase and maintain them. Is there rent involved? Production and duplication of course materials. Are you buying your course materials or are you making them? Patient supplies, office supplies, refreshments, and miscellaneous expenses all are factors that affect a pulmonary rehab budget. Potential hazards. Cardiac events are always a potential hazard when working out. Blood gas anomalies like drops in blood in PO2 or rises in CO2 can also happen. Muscle strains, sprains, and twitches also can happen. And you can also get exercise-induced asthma, hypoglycemia, and dehydration. These are all things that you should be prepared for. And also make sure that you have a thorough onboarding with your patient so that you know whether they're diabetic, asthmatic. All diabetics should carry a blood sugar monitor and things to deal with hypoglycemia. sugar pills, protein bars. Asthmatics need to have their rescue inhalers on them at all times. And everyone should have water with them in the gym, and you should have extra water bottles available for people. Last but not least, let's talk a little bit about the first cousin of pulmonary rehab, cardiac rehabilitation. Cardiac rehabilitation deals mainly with cardiac disease and is focused on improving cardiovascular fitness. Cardiac rehabilitation is defined as a comprehensive exercise and education program designed for patients with cardiovascular disease. Similar to pulmonary rehab, good cardiac rehab programs are multidisciplinary in approach and focus, and goals include patient education and promoting heart-healthy living, physical reconditioning to improve work capacity, weight loss, and a return to work. Enrollment in cardiac rehabilitation programs is based on a thorough cardiovascular evaluation and related cardiovascular parameters. The goal of a structured cardiac rehab program is to assist patients in developing a regular pattern of safe exercise to achieve greater cardiovascular performance during activity. Most cardiac rehab programs are conducted within a hospital facility. Programs are generally divided into monitored and maintenance segments with home options available. Exercise prescriptions are individualized for participating patients to maximize outcome and reduce the likelihood of adverse effects. Pulmonary and cardiac rehabilitation often share many similarities and differences. Similarities include the need for patient evaluation before program enrollment, patient education, and focus on exercise to increase fitness and stamina. Most cardiac patients range in age from their late 30s all the way to their 70s, whereas most pulmonary patients are greater than 50 years old. Exercises used within the program are similar. However, many cardiac patients can walk for up to an hour, where this may be virtually impossible for most pulmonary patients. Reimbursement varies within the two types of programs, with cardiac rehabilitation being more recognized by insurance payers, including Medicare. Because cardiac rehab has existed longer than pulmonary rehab, and because outcomes tend to have greater validity and acceptance, insurance reimbursement is more readily available for cardiac rehab. There are 4 phases to cardiac rehab, from program introduction to the ongoing fitness aspect. Patient reimbursement depends on what phase of cardiac rehab the patient is in. This division into phases does not currently exist for patients in pulmonary rehab. And finally, respiratory involvement in cardiac rehab is significantly less. For the most part, the RT is involved with instruction on O2 use and may assist with patient exercise sessions during cardiac rehab. Most often, the cardiologist and cardiac nurse specialist are the ones involved with program facilitation and administration. This is the end of the program on pulmonary rehabilitation. Thank you so much for your time and attention, and I hope you've enjoyed this lecture. Have a great day. Goodbye.